All right then. Thank you everyone for coming, and a warm welcome to all of you. My name is Jeremiah Chakaya, and I'm the current president of the International Union Against TB and Lung Disease, what we commonly call the Union. I want So, again, a warm welcome to all of you. My name is Jeremiah Chakaya, and I am from Kenya, and I'm the current president of the International Union Against Tuberculosis and Lung Disease, or commonly the Union. I want to welcome you to this official opening press conference on TB prevention. As you know, the Union is the custodian of the conference, the 49th Conference on Lung Health, that is taking place this week in the city of Hague. And I'd like to repeat what my colleague Paul Fujiwara said yesterday, that it is important that we maintain the momentum around TB in this post-United Nations high-level meeting. Let me briefly say a few things to set the scene today. The UN high-level meeting on TB, which happened a month ago, and the political declaration signed by world leaders has made it very clear what we need to do and what we'll need to be championing for years to come. That to end TB epidemic, we need better preventive tools. We need better diagnostics, we need better drugs, we need more of those drugs, and of course we need an effective vaccine. So of course, we are delighted to see the emergence of some good science and prevention being presented in this conference this week. On that note, we should start. And first, a little bit of housekeeping. This press conference is being live streamed on the conference website, and an archived recording will be available on the conference Facebook page later. To those of you who are watching online, you are warmly welcome. We will be hearing a few remarks from our speakers, and then I will open it up for questions. Once the press conference has ended, you can, of course, approach our speakers for one-to-one interviews. I would also like to point out that a spokesperson from Johnson & Johnson will be available at the conclusion of this press conference to speak to any journalist on the issue of bedaquiline pricing that came up yesterday, for those of you who are interested in doing so. Our first speaker for this press conference is Lawrence Gunde. Lawrence Gunde is a TB HIV program specialist based at the Centers for Disease Control and Prevention in Malawi. Lawrence will discuss some work around early phase implementation and the successes that they have had in Malawi with Izone preventive therapy for people living with HIV. May I now please welcome Lawrence to give his remarks.
Thank you. So just a bit of background. We know that despite TB being a preventable and treatable disease, it still remains a very important cause of morbidity as well as mortality in people living with HIV. And also, one of the facts is that isoniazid preventive therapy has been discovered to be one of the most important interventions or life-saving interventions for latent TB infection treatment in people living with HIV. So in late 2017, Malawi began to scale up the use of IPT to eligible people living with HIV that were initiating in care, as well as those that were already in care in the 5 high TB HIV burden districts. 2 months after the scale up, we conducted a study that was aimed at measuring the frequency as well as the timeliness of early phase IPT uptake among people living with HIV that were initiating in care in these 5 IPT districts. We actually conducted a cross-sectional medical records review at 6 randomly selected CDC-affiliated ART facilities in urban cities of Lilongwe as well as Blantyre. In this study, we actually sampled 271 against a target of 300 medical records for people living with HIV that were initiating in care. And what we noted was that there was good documentation that all of them actually underwent TB screening, and only 10% were screened positive for presumptive TB. Among the eligible people living with HIV that were initiating in care, there was an overall IPT uptake of about 70%. And we found out that the weighted uptake in children that were less than 15 years of age was actually significantly lower than that for adolescents that were 15 years or higher, and adults, with 30% in children less than 15 years of age and about 72% in 15 years above people living with HIV. For people living with HIV that were less than 5 years of age, we found out that their weighted IPT uptake was even lower, which was only about 13%. And further to that, we found out that the IPT uptake in pregnant women was actually comparable to women that were non-pregnant in this particular sampled population. We also tried to look at the timeliness in terms of IPT starts. We know that we're implementing the test and treat for people living with HIV, whereby once they're tested positive, we would like them to start on ART, and we also try to find out if IPT starts were actually aligned with that particular strategy, and found out that about 91% of the people that were initiated on IPT were started on the same day that they were started on ART. These results, or these findings, actually demonstrate an effective early phase scale-up of IPT among people living with HIV in Malawi, which may serve as a model for other countries that are planning to implement similar national programs. And also, Malawi underlines the importance of early phase assessments for scale-ups such as the IPT program, whereby opportunities for improvement in the program can be identified as early as possible and be rectified for quality provision of IPT. Well, the CDC division of global HIV and TB is also on the front lines in over 25 countries, trying to help governments or partner governments in finding, treating, as well as preventing TB, especially in people living with HIV, and help sustain such efforts. Thank you so much.
Thank you very much, Lawrence, for that overview of what's happening in Malawi. Our next speaker is Lisa Adams. Lisa is Associate Dean for Global Health and Associate Professor of Medicine at the Dartmouth Medical School in the U.S. She's been working on integrated care and patient empowerment to enable patients make choices as a methodology for enhancing isoniazid preventive therapy. Lisa will talk briefly about a study on isoniazid preventive therapy in Swaziland. You have the floor, Lisa.
Thank you, and good morning, everyone. I'm very pleased to share our results that demonstrated that integrated care and patient choice enabled treatment completion of isoniazid preventive therapy, or IPT, among persons living with HIV in Swaziland, now renamed Eswatini. We know that despite international recommendations and endorsements globally, the uptake of IPT, a 6-month course of IPT, has been poor, as has treatment completion rates. And this has been true among those at highest risk, such as persons living with HIV. So 2 years ago, we conducted a prospective cohort study in which we enrolled 908 patients across 5 HIV care facilities in Eswatini into an IPT program. And we employed 3 interventions. First, we offered patients a choice in their IPT delivery. They could choose between facility-based or community-based care. Secondly, we aligned their IPT with their antiretroviral therapy meds. We made isoniazid like one of their antiretroviral medicines. We made it part of their ART package. Thirdly, we conducted motivational interviewing among the healthcare workers to encourage them to engage with patients about what matters most to those patients and what motivates their behavior change. And our results were astounding. We had 95% adherence and 89% treatment completion compared to the usual 40 to 50% treatment completion rates. But we neglected to ask our patients why they successfully completed therapy, what mattered, what made a difference. Was one intervention more important than another? So that led to our current study, in which we determined what factors favorably influenced their adherence and treatment completion. This was a mixed method study, so we had both open-ended and closed questions using quantitative and qualitative research methods. We identified 150 patients who had completed IPT in our first study, and we stratified the study group across their choice of delivery model and basic demographics to get a representative sample. Our Swazi research team interviewed patients in person at their healthcare facilities using a standardized interview guide, asking them what helped them complete treatment. Out of 150 interviewed, we analyzed data for 136 patients, excluding 14 who did not recall being offered a choice of IPT delivery. And what we learned was that all 3 interventions seemed to be critical. So nearly all, 99%, reported that linking IPT with their antiretroviral refills was important. They said things like, "We were used to taking ART. We just added IPT to our normal routine." Also, linking refill pickups served to save time and transportation costs for patients. Similarly, 90% said that being offered a choice was important, even though most patients chose the facility-based care model, which is the model we might have assigned them to if we weren't giving them a choice. They said that it mattered to have options and to be able to make a choice, and that they felt more engaged in their care. Many also cited healthcare worker friendliness and respectful education that they received as a positive influence. And we were impressed with their knowledge of both TB and IPT risks and benefits. Lastly, an unexpected finding was how many disclosed that they were in a study and taking IPT. 95% of our patients told a relative or friend about their IPT. So it seemed that strong social support helped them complete treatment, and those without that support seemed to be struggling with their adherence. So we concluded that all 3 interventions play an important role. Offering a choice, increased patient engagement and empowerment. Linking IPT with ART provided person-centered care. And we speculate that the motivational interviewing may have improved healthcare worker communication and the patient education. So our next steps are national rollout and scale up in similar high TB/HIV burden settings. And we've developed an IPT toolkit that will be available soon online to help facilitate dissemination. So I feel there are just 3 final high-level takeaways. This study really showed again that our healthcare systems must integrate preventive services like IPT into existing and valued services like our ART programs. This is simply better person-centered care. Also, offering patients choices about how to receive their TB care makes them feel more respected, empowered, and engaged in their care. And this is also in line with the promotion of differentiated service delivery. And lastly, high-quality patient education can support disclosure, which can help dismantle stigma and empower patients to be successful in their own health care. Thank you.
Thank you very much, Lisa, for those remarks, again emphasizing the role of patient empowerment in our health programming. Our third and final speaker is Valérie. Valérie is a program manager for Francophone Africa, the Union. As you may be aware, the Union has a beautiful photo exhibition called The Silent Epidemic, that is on display this week in the atrium at the Hague City Hall, and I urge you to see it if you've not already done so. Many of the pictures taken in this exhibition are of children who are part of the TT prevention study undertaken by Valérie and her colleagues in Francophone Africa. So we are very excited that Valérie is here today to share with us some very exciting results from this study. Please go ahead, Valérie.
Thank you. So you know very well that tuberculosis is not only a deadly disease, but it's also very contagious. So we all know that children who are living in the household of pulmonary TB patients are at high risk of getting infected. And moreover, younger children are at very high risk of getting the disease and severe disease. So it is really now recognized that screening children in contact with pulmonary TB cases is among the most effective strategies to detect and to prevent TB. And a recent paper showed that full implementation of household contact management would prevent more than 160,000 cases of tuberculosis and more than 100,000 deaths in children. So while contact investigation and preventive therapy is strongly recommended for children, especially children under 5, we estimate, and WHO estimates, that over 75% of children who are eligible for this intervention do not access preventive therapy. So the Tittie Study is an implementation study which was conducted on and coordinated by the Union in 4 countries in Francophone Africa: Benin, Burkina Faso, Cameroon, and Central African Republic. The study sites were 13 health centers situated in the capital city or large city in those countries. And basically all adults with recently diagnosed pulmonary TB were enrolled after informed consent if they had children at home. And we conducted home visits with a family questionnaire, clinical child assessment. Children were evaluated with tuberculin skin test also and chest x-ray, and visited a nurse at the health center. In case of symptoms, the child was referred to the doctor, and if TB was diagnosed, the child was put on TB treatment. If no active TB was detected, preventive therapy was given. The particular feature of this study is that the preventive therapy regimen which was offered was a shorter regimen of 3 months of isoniazid and rifampicin in 3 of the 4 countries, as opposed to the standardized, generally used regimen of 6 months of isoniazid. So children were then followed up through monthly visit and then by quarterly visit up to 12 months after treatment completion. So the preliminary results of our study showed that we enrolled more than 1,000 index TB patients with almost 2,000 children. 1,973 children were enrolled in the study. 105 cases of active TB were diagnosed at baseline, which means around 5% of the children who got active TB and were put on treatment. 90% of the children could start preventive therapy, and out of them, 92% completed the treatment. That is, the treatment was very well tolerated. There was only 1 child who had to stop the treatment because of adverse events, severe vomiting, and adherence to treatment was excellent, both for the 3-month regimen and the 6-month regimen. And so far, no active TB case have been detected during the follow-up. So these preliminary results show that really preventing TB with a short regimen appear to be well accepted, feasible, and that the contact investigation activities is really a feasible strategy to implement within the context of the health system. Standard tools have been developed, training of health staff have been conducted, and the rollout and the scale up of these activities in this country is hopefully taking place. Thank you.
Thank you very, very much, Valérie, for summarizing the results of that very important study that shows that contact management is key to reaching children who potentially could have TB and using interventions that can prevent TB in these children. We now have the opportunity to take questions. Microphones will be available, could be passed around to those who want to ask questions. Please, when you pick up a microphone and I call on you to speak, it would be great if you can say your name and which media outlet you come from. Let's also try and keep the questions brief and also let us know among the three panelists here who your question is directed to. Yes. Can we have the microphones?
Yep. Okay. Yeah. Which question? Hannah, is it you?
Here. I saw this hand first.
This one?
Yes.
No, you keep burning questions first.
It's fine. No, mine's
It's a smoldering question. Okay, thank you very much. I'm Howard Armstead. I'm representing the Public Eye newspaper in Lesotho, and I may also be being published in Swaziland and Namibia and Botswana, which are all high TB rate countries. In Southern Africa has some of the highest rates of TB in the world. It seems that you've reported a lot of good news here, and we don't always get good news from TB. I don't know if my question will be short or not, but I'd like to say that when we're trying to prevent any disease, TB or any other disease, we should be using every tool in the toolbox that we can possibly use, as long as it's effective, it's scientifically based, and it's economically feasible to use and practical to use those tools. So I want to know, in my own research, I've been HIV positive for 34 years. I've never had TB. I've never been sick with HIV because I've been on ARVs for 28 years approximately. Yet I've also added something called selenium, to my therapy, and that is what my research is focused on, the use of selenium in HIV and also in TB. We know that in Malawi, for instance, 80% of the population is deficient in selenium. And selenium is a key element for the immune system, and it can increase CD4 count. It affects the thymus gland, where CD4s are produced, and the balance between CD4-CD8 ratio is established. The question is, should we not be using the effective immunotherapy, even though it may not be a drug, maybe it's nutritionally based, if it's been proven to increase CD4 count? Because we know that HIV patients, for instance, that are below 135 CD4 count are 13 times more likely to have active TB. So if you can boost the CD4 count through use of a nutritional supplement that does that, shouldn't we be using that as an additional tool in our toolbox against this disease?
So I suppose your question goes to all the three. Let's take another one before the three.
Sorry, my name is Hannah McNeish. I'm a freelance journalist working mostly for British press. My question was to Valérie and to you, Jeremiah, and anyone else that wants to take it on. I just wondered what, considering that the WHO recommends preventive therapy for so many children, you know, why are so many children not receiving this? What are the barriers? Is it drug prices? Is it a lack of medical staff? Yeah, just to get that one explained would be great.
So let's take those two first. Who wants to respond to Howard's question about the use of nutritional supplements and selenium in HIV-infected individuals to improve, you know, immune status, CD4 counts, and therefore prevent infections like TB?
It's not an area of expertise for me, but I will just maybe answer more generally and agreeing that we should be using everything we have in our armamentarium to combat both TB and HIV. And I'm always very supportive of studies to try to help identify those low-hanging fruit options that might be available, be they nutritional supplements, you know, different programmatic interventions. As I said, my work has been around patient empowerment and you know, offering choice and sort of shared decision-making piece, which again seem like some low-hanging fruit, not too costly options to include in what we have in terms of trying to help support and treat TB and HIV. So I'm supportive of you know, once we have the research to demonstrate that that there are new tools, new options for treating both diseases or patients who with co-disease. And it's really just then it becomes the barrier of programmatic implementation and acceptance and those early steps, which I think will be some of the challenges that we'll talk about in the next question as well. Thank you.
I think, as you know, undernutrition is a major issue. Tuberculosis is social disease. Tuberculosis is a disease that's related to poverty, and poverty means then access to food too can be a big issue in those situations. So yes, undernutrition is a risk factor for tuberculosis. What I don't know is whether there has been I know there have been nutrition programs, but those happen after TB diagnosis, and the purpose is sometimes been to try and see whether you can keep people on treatment or improve treatment outcomes. And in relation to treatment outcomes, nutritional programs have not really been they have not been successful. But really, whether you can go into a community and give people food to prevent TB, I don't think anybody has done that kind of wide-scale, great study to be able to say, yes, if you provide certain types of food to people, you will prevent TB. It's a good thing to start thinking about, and maybe we should undertake relevant research in this area. But I think the most important thing is if we can, and this gels very well with the topics that were discussed at the plenary session today. It's a social disease, social determinants of disease, and therefore, if we can improve the socioeconomic status of populations and make them nutritionally better, probably TB rates will go down. The issue of why children are not getting IPT on as wide scale as they should be. Maybe Valérie, you can take that.
Thank you. Very, very excellent questions. I think there are many barriers to this because this is a simple, affordable, and practical activity that could be implemented. You mentioned drug supply. Drug supply is an issue, but as you can see, for example, this regimen of 3 months of isoniazid rifampicin with child-friendly formulation that are available everywhere, they should work, and countries should easily get procurement of these drugs. But there are many barriers for that, and even the funding now of a lot of countries is now stepping out for the procurement of first-line drugs. And there is a lack of political commitment at the country level sometimes to procure those drugs. And we have seen many stockouts in several countries for these particular drugs. Many programmatic barriers. And you mentioned the staff. This is one of the difficulties. Not enough staff, lack of involvement of community health workers, lack of training, and there are a lot of solutions that can be proposed. And we have seen that with adequate training and standardized tools that can be distributed, there is a lot of things that can be done. So many missed opportunities can be overcome by these simple measures. And of course, I think also the people can have to get convinced that it works. And I think we show that in such a study that this is the case, because family get convinced and the staff get convinced. At the first time, it was not so easy because TB staff tend to think that it's very difficult to approach families because of the stigma of tuberculosis. But with a good interaction with the families are very happy to get the intervention. So the conviction, people can get convinced, family, staff, and everybody in the community. And then this is the barriers that can be alleviated.
So maybe just to add one little thing, I think the issue really is we have in the past not prioritized at program level. I work at the country level. It's been a prioritization problem at country level. And related to that, the building of systems around preventive therapy, because you cannot just deliver you've got to have the systems, like Valérie said. It has to be in your strategic plan. It has to be you got to plan for training people. You got to hire community healthcare workers. You got to train them and all those kind of things. So if you prioritize, you mobilize resources for it, you build the systems around it, you can then implement it, and that has not happened for some reason. Can we then take two more?
Follow-up questions.
Yes, please.
Sorry, Valérie, I just wondered if you could give any examples of the countries that have had stockouts, or where you've seen the buying of TB drugs is falling.
Let's take another question. So two or three is the last ones for this session, because unfortunately we're running out of time. So please.
Hi, I'm Rabita Aziz. I write for the scientific blog of the Infectious Diseases Society of America, Science Speaks. This question is for Dr. Adams. Could you confirm or just give more information about the sites where the ART and IPT integration occurred? Were they PEPFAR funded or Global Fund funded?
Please.
Yes, good morning. I'm Emilio de Benito, work for a Spanish newspaper, El País, and I have a question about these preventive treatments. How long does it last? I mean, if you go to a house and there's a child who is living with his parents and his father is in TB, and you give him the treatment, what happens if 2 years later it's his mother who has the TB? Do you have to repeat the treatment, or is already prevented? How long does this effect work?
Thank you. So, Valérie and Lisa, start.
Okay. Stockouts. I can't just name country. I think that almost all countries have faced stockout of first-line drug for TB at some point in the last 5 years. I don't know if I'm maybe provocative, but at least at the central level, I've seen programs with stockout of first-line drug, including those drugs for preventive therapy. They are in the list of the first-line drugs that should be always there in any country. Otherwise, the program doesn't function. And I think all have experienced stockouts. Maybe I'm provocative, but Dr. Chakaya.
No, you are not. If you say the last 5 years, I think the answer is yes. A lot of countries do have disruptions in their anti-TB stock levels at some point. It's stabilized quite a bit in the last few years. We're seeing fewer and fewer countries because there's been a great effort at the international level to ensure that that doesn't happen. So the Global Drug Facility and others are keenly looking at stock levels in countries, especially high-burden countries, and we are seeing less and less disruptions in stocks of anti-TB drugs recently. But if you go 5 years down the line, yes, it was an extremely common problem.
I just wanted to answer the question on the lasting of the intervention. Yes, the preventive therapy works when during the period it is given. But you give an example. In the same family, you have TB patient, and 2 years later, there is another TB patient in this family. Let me ask the question again. In fact, when you are visiting the family, one of the result of the investigation is usually some other patient can be detected through this investigation, and even all other adults. And you know that now the WHO is recommending contact investigation and preventive therapy for all contact of all ages. And as a result of this investigation, it is very likely that also adults would be adult TB would be prevented, and other secondary cases could be detected through this investigation. So this situation you are proposing maybe will not exist, because this mother will not get the TB in 2 years from now because of the intervention.
So in HIV-infected individuals, we've learned, especially in Africa, that maybe a 6-month course of isoniazid preventive therapy will probably protect you for about 18 months or so. The Butusa study done in Botswana showed very clearly that longer-term IPT is better than short-term IPT. And in fact, people now are talking about lifelong IPT, as it were. And the reason for that is that there's a lot of pressure of reinfections in those parts of the world. In other parts of the world where the pressure for infection, reinfection is lower, maybe shorter-term treatment might be just as good. Lisa.
And I just will add one statement to that before I get to the last question, which is that the nicest analogy that I've heard is from Gavin Churchard, a researcher in South Africa, who said IPT, or any preventive therapy for TB or treatment of latent TB infection, is like an umbrella. So if it's raining, you want to keep that umbrella open all the time. So think about IPT. If you are living in a place where you are constantly being exposed and at risk for being reinfected, you want to have your umbrella up. If you're at a place where there's not very little rain, maybe one rainstorm, you have your umbrella up, and then you can put it away. So think of IPT as an umbrella in a rainstorm. And is it raining outside all the time? That's, I think, a nice analogy to help figure out what the importance of IPT. So in terms of the sites, the 5, they were all HIV care sites, publicly run sites. 4 were in urban areas, 1 was in a rural area, 1 was 4 of them saw both adults and children. 1 was pediatric focused, but did see the adults that were associated with those kids. And I could check on the funding. There were, as I said, they're all public sites, but I believe that there was PEPFAR, and I don't know if there had been recent global fund to help support the care and provision of medicines, but I can find that out for you.
So thank you. Unfortunately, we have to end this session because this is the time we had. Thank you all of you for joining us. And like we already said at the beginning, our panelists will be available to engage with you one-on-one at the end of this press conference. So thank you again, and we've come to the end of this conference. Please enjoy the conference. Thank you.
I'd just like to add for those who missed the announcement before, that Adrian Thomas, the Vice President of Access at Johnson